In previous video, we have discussed about introduction of pain, then pain transmission. In pain transmission, we have discussed about different types of nociceptors, the pain mediators, different types of fibers which are carrying the pain, and components of pain. Now today we will discuss about pain pathway and its central connections. But before starting the lecture, let me ask you few questions regarding the pain. So have you ever wondered why people start sweating in case of severe pain? Or why many people, especially children, pass out the urine if they experience severe sudden pain? Or why different people experience different intensities of pain with same kind of injury? And why do you rub your cheeks if someone slaps you? And why do you start crying if you experience severe pain? And if you see something horrible like profuse bleeding or very painful act like someone is very badly beating a person, you start shivering, sweating, and sometimes start vomiting, especially females. And if someone hit you with a hammer, you will immediately withdraw your hand or withdraw your feet where someone has hit you. And even you look at the part where you got the hit, and even you start rubbing it. And have you ever wondered why you cannot sleep if you are experiencing the pain? Have you ever thought why all these things happen? Now you will get all these answers in today's lecture. So let's begin with pain pathway. Even though all pain receptors are free nerve endings, these endings use two separate pathways for transmitting pain signals into the central nervous system. The two pathways mainly correspond to the two types of pain. A fast pain pathway, also called as neo-spinothalamic tract. We are saying it neo-spinothalamic tract because it is newer one, or we can say it is discovered recently. And the slow pain pathway, also called as paleo-spinothalamic tract. We are calling it paleo. Paleo means old. So it is the oldest tract. I mean it is discovered earlier compared to neo-spinothalamic tract. So that's why we say it is a paleo-spinothalamic tract. There is one more tract called as archi-spinothalamic tract, but I am not going into detail of archi-spinothalamic tract. So now these two pathways, that is neo-spinothalamic tract and paleo-spinothalamic tract, they pass through lateral white funiculus of the spinal cord to reach the thalamus. Here they are together known as lateral spinothalamic tract. We are saying them lateral because they pass through lateral white funiculus of the spinal cord. And we are saying it spinothalamic because they pass from spinal cord to the thalamus. And we are saying it as tract because they form a bundle. Now let's begin with neo-spinothalamic tract. So whenever any noxious thermal or mechanical stimuli stimulates mechanical or thermal nociceptors, these impulses are then transmitted via the peripheral processes of thinly myelinated A delta fibers, which are conducting at the velocity of 12 to 30 meters per second. Then these impulses, they reach the cell bodies of these neurons, which may be located in the dorsal root ganglion if the impulses are coming from areas other than face and cranium, or they may be located in trigeminal ganglion if the impulses are coming from face and cranium. Now first let's discuss the pathway for those impulses which are coming from the areas other than face and cranium. So these impulses They travel through the central processes of these neurons, which then form synapse in lamina 1 and 5 of dorsal gray horn of spinal cord. From here, second order neurons they start, and they immediately cross to the contralateral side through the anterior white commissure of the spinal cord to reach the lateral white funiculus, and then they ascend upwards to ultimately reach the ventral posterolateral nucleus of thalamus. But before reaching the thalamus, these fibers they form a bundle in the brainstem along with the other tracts. They are anterior spinothalamic tract and spinotectal tract, and this bundle it is known as spinal lemniscus. Remember, there are two other lemnisci like medial lemniscus and lateral lemniscus. Those are different things, so don't confuse them with the spinal lemniscus. So now come back to topic. So some of these second order neurons they also give collaterals to reticular formation before reaching the thalamus. Then finally, these second order neurons they terminate in the ventral posterolateral nucleus of thalamus by making synapse with third order neurons, which then pass through the internal capsule to reach the somatosensory cortex. Now here we must remember one important point, that the neurons in this pathway maintains highly organized somatotopic arrangement, where the neurons which are coming from lower part of the body they are arranged laterally, and those neurons which are coming from upper part of the body they are placed medially throughout this tract. Now let's come to A delta fibers which are coming from face and cranium. These fibers, as we already said, having their cell bodies in the trigeminal ganglion. From here their central processes start and travel all the way to synapse in the nucleus of trigeminal nerve. From here the second order neurons begin their journey towards the thalamus. These neurons they form the ventral trigeminothalamic tract while crossing the midline to the contralateral side, and then ascend upwards along with the contralateral dorsal trigeminothalamic tract, forming the trigeminal lemniscus, and then finally terminating by forming synapse with third order neurons in ventral posteromedial nucleus of thalamus. Then these third order neurons they pass through the internal capsule to reach the somatosensory cortex. Now look at this image here. It is showing neospinothalamic tract which we have discussed just now. Fibers which are drawn in red shows the pathway which is transmitting sensations from areas of the body other than face, whereas the fibers which are drawn in the green shows the pathway taking sensations from face and cranium via the trigeminal nerve. So that's all about the neospinothalamic tract. Now let's discuss about paleospinothalamic tract. So stimulation of polymodal nociceptors transmits the impulses along the peripheral processes of unmyelinated C fibers, which conduct the impulses at the velocity of 0.5 to 2 meters per second. Remember, earlier we have discussed A delta fibers transmit the fast pain and C fibers transmit the slow pain. So here these fibers they are transmitting the impulses at the velocity of 0.5 to 2 meters per second, which is slower than the A delta fibers which transmit at the velocity of 15 to 30 meters per second. So these impulses then they reach the cell bodies of these neurons, which are located in the dorsal root ganglion, if the impulses are coming from areas other than the face and cranium, or they may be located in trigeminal ganglion if the impulses are coming from face and cranium. So let's first discuss the pathway for those fibers which are coming from face and cranium. So these fibers, as we already said, having their cell bodies in the trigeminal ganglion, from here their central processes start and travel all the way to synapse in the nucleus of trigeminal nerve. From here, the second order neurons begin their journey towards the thalamus. These neurons then they form the ventral trigeminothalamic tract while crossing the midline to the contralateral side, and then ascend upwards along with the contralateral dorsal trigeminothalamic tract, forming the trigeminal lemniscus, and then finally terminating by forming synapse with third order neuron in the intralaminar nuclei of thalamus. Remember, for the fast pain pathway, these fibers they are terminating in the ventral posteromedial nucleus of thalamus, whereas here they are terminating in the intralaminar nuclei of thalamus. Then these third order neurons they pass through the internal capsule to reach the somatosensory cortex. Now let's proceed to the main pathway whose fibers are coming from areas other than face and cranium. As already mentioned before, that these neurons have their cell bodies in the dorsal root ganglion. From there, the central processes begin and proceed towards the dorsal gray horn of the spinal cord, where they give collaterals which ascend 2 or 3 segments up and down, forming a local tract which is called as Lizauer's tract. And then the main central fibers of these first order neurons they proceed and form synapse in the lamina 2, also known as substantia gelatinosa of dorsal gray horn of spinal cord. Most of the signals then pass through one or more additional short fiber neurons within the dorsal horn themselves before entering mainly into the lamina 5, which is also located in the dorsal horn. Here, the last neurons in the series give rise to the long axons that mostly join the fibers from the fast pain pathway, passing first through the anterior commissure to the opposite side of the cord, then upwards towards the thalamus in the lateral spinothalamic tract. Now, while moving upwards, these fibers pass through the spinal lemniscus and then terminate in ventral, posterolateral and intralaminar nuclei of the thalamus. Let me repeat, they terminate in the ventral, posterolateral nucleus and intralaminar nuclei of the thalamus. Remember, in case of fast pain pathway, these fibers they are terminating in the ventral posterolateral nucleus of the thalamus, whereas here they terminate in the ventral posterolateral as well as intralaminar nuclei of the thalamus. But before reaching the thalamus, they give collaterals to the reticular formation. To be more specific, we can say ascending reticular activating system or ARS. Then this pathway also gives collaterals to periaqueductal gray matter, PAG. It also gives collaterals to nucleus raphe-magnus, tectum, and also to the hypothalamus. Then from intralaminar nuclei, these neurons project to the multiple higher areas of the brain, such as cingulate gyrus, insular cortex, amygdala, hippocampus, and also to the whole cerebral cortex. And from ventroposterolateral nucleus, these fibers project to the somatosensory cortex. So that's all about paleo-spinothalamic tract. Now let's discuss about the significance of central connections of these pathways which we have discussed above. So both slow and fast pathways, they give collaterals to reticular formation or ascending reticular activating system, ARAS. This helps in keeping the brain alert and thereby does not allow the person to sleep and forces the person to keep trying to address the source of pain and thereby to prevent further tissue damage. Now slow pain pathway, it gives many central connections. Let's begin with intralaminar nuclei. These intralaminar nuclei project to multiple higher areas including whole cerebral cortex, which also helps keeping the person alert and awake until the noxious stimuli are removed. So now you understand why the person cannot sleep if the person is experiencing severe pain. Then slow pain pathway also gives collateral to cingulate gyrus, which adds emotional component to the pain and contributes to the unpleasantness of pain and also acts as memory hub for painful events. It also contributes to cognition and response selection. Then slow pain pathway also gives collateral to insular cortex. This is the area where the sensation of pain is judged as to its degree or intensity. Further, the insula is the area where a person imagines the pain when looking at the images of painful events while thinking about their happenings to one's own body. It also adds autonomic component like nausea, vomiting, sweating, etc. So patients with lesion of insular cortex, they present with striking syndrome of asymbulia for pain. These patients, they perceive noxious stimuli as painful and can distinguish sharp from dull pain, but they fail to display appropriate emotional responses to the pain. These observations, they implicate the insular cortex as an area in which the sensory, affective and cognitive component of pain are integrated. Then collaterals to amygdala and hippocampus creates and encode the memory and emotion due to painful stimuli. Then somatosensory cortex, it helps in determining the exact location of pain, its duration and even its quality. So that's all for today. In my upcoming video, I will discuss about pain perception and pain modulation. So keep watching. Thank you. Have a nice day.